Alrighty, everybody, let's get into it again. Therapeutic drug categories, and this is based off of chapter 5 in your text. Pharmacology is, to say the least, a struggle. So in order to make this talk go a little bit better, there's going to be a couple fun surprises to help take our mind off of it a little bit. So when it comes to pharmacology, this is like the epitome of learning pharmacology. I have no idea what I'm doing. And it doesn't matter how much you study it, there's always a piece of this because the new medicines coming out, everything that goes on, there's so much that goes into it, it's impossible to stay on top of it all. And so our goal for you in this course really isn't to try to do that. It's to give you kind of a basic overall understanding of pharmaceutical classes and things you guys should be on the lookout for. But even still, the main responsibility for these medicines and for everything going on lies on the prescriber. Okay, so we're going to talk about anti-inflammatories, which is something you guys would have quite a bit of exposure to. And there's a couple of different types of anti-inflammatories that we use. But first, let's talk a little bit about just the role of inflammation and injury. Why does inflammation happen? So it doesn't matter if an injury or an irritation is caused by like a mechanical issue, such as like rolling your ankle or something with your knees, or if it's caused by a noxious foreign substance like allergens. The same cascade takes place. So prostaglandins, histamine, leukotrienes, bradykinin, all these different mediators, and if you so choose, there's a figure in your book, but please don't spend your time trying to, memorize that. But all of these different mediators are released by that site of injury or irritation. And essentially what happens is the red blood cells and the arteries close to that location become a lot more dilated, like intense vasodilation. And what happens is, in order to make those capillaries more leaky, in order to let all of these different molecules recruit themselves to that area, okay? So if we think of the case, say I fall, cut my arm, in that area, all of those different mediators are going to be released by that area to signal more cells to come to that area. So I'm looking at tissue healing and infection prevention, right? And so in order for those things to take place, we need more cells to be there. And those cells, when they do get there, they need the energy that they need to function. And so all those mediators are released. Those extra white blood cells, platelets, lots of different cells come to that area to help both with infection and tissue repair. But with that inflammation itself causes the pain, redness, warmth, and swelling, and that loss of function that you see. So it's also important to know that inflammation can occur both acutely, like in that instance that I cut my arm or I sprayed my ankle, or it can be chronic. There's lots of sources of chronic inflammation, whether it's arthritises or autoimmune diseases. There's a lot of different things that can be playing a role in that. So if we think about what medicines do we have to give for to stop this inflammatory process. And that seems a little counterintuitive because we just talked about how that inflammation helps our body heal. But like we said, it also causes a lot of symptoms. So it's a balancing act here. So we both have non-steroidal options and steroidal options. So the non-steroidal options are like your ibuprofen or naproxen and such. Their main goal is really just to, decrease pain, inflammation, and fever. Okay, those are kind of our first go-to options. Okay, then if you move over to the other side, the steroidal options, these are a lot more of a heavy hitter. Like something seriously going on, we need extensive therapy here. So the glucocorticoids are the ones that I'm most familiar with and I use the most often. The important thing to keep in mind with them is the amount of immune system suppression that occurs. This can be a good thing if I'm using it for cases like inflammatory arthritis. I want to kick down that immune system's ability to create all of that crazy inflammation havoc. But if I also kick down their immune system to stop itself from attacking itself, like in the case of autoimmune diseases, I'm also limiting that person's ability to fight infection. So if people are on high doses of glucocorticoids long term, they can have quite a bit of susceptibility to infection. I know you guys are probably more familiar with corticosteroids being used in like injection form. Okay, whether it's in the intrasynovial or intraarticular or that iontophoresis, which, like I said, I've never used, but you guys are a lot more familiar with. Those are kind of your instances, but we can use it kind of systemically as well. And then the mineral corticosteroids, I don't use as often, but the important thing to know about those ones is they help regulate your electrolytes. And so you can have some electrolyte abnormalities. With me and my background, I hear electrolyte abnormalities, I think, arrhythmias. With you guys, potentially you guys are thinking more of, muscle cramping and those kinds of things. But it's important for both of us to kind of see outside of our narrow scope and think about other indications as well. Yeah, like I said, we need a break. We need to pause. We need to stop to think about this. And like I said previously, don't get super caught up in some of the nitty-gritties that we're going to go into here, like the inflammatory cascades and those kinds of things. It's great to have an awareness of, but I wouldn't necessarily spend my time focusing on it. Okay, so let's talk a little bit more about those NSAIDs. Table 5-1 goes into that a little bit more. Like I said, they inhibit those prostaglandin syntheses, or synthesi. Anyways, like I said, all of those different prostaglandins are those mediators that recruit all of that fluid and all of those extra cells to that area. Okay. Figure 5-3 is another one that kind of goes into how do the NSAIDs activate the enzymes that actually break down the prostaglandins. Like I said, super nitty-gritty, not necessarily that important to have memorized, but just to have an awareness. When we think of NSAIDs, the predominant side effects are GI side effects. Okay, so and you'll find with a lot of the medicines that we talk about, GI side effects are what you need to be aware of. Okay, and so we're looking at, dyspepsia, heartburn, nausea, vomiting, abdominal pain, and even peptic ulcers and GI bleeding. And so in order to decrease these side effects, they should take it with food or with milk. You never want to take, NSAIDs on an empty stomach. Okay, and then also we think of aspirin. Aspirin really inhibits your platelet function, and this is a great example of that. Like, over the counter does not mean that a medicine is safe, okay? So aspirin is over the counter and it never should be. So if people take, like in this instance, aspirin really mitigates your platelets and how they function. And with a lot of people that can be pretty detrimental. If a child takes too much aspirin, they go into Reye's syndrome, and that's an entirely different conversation. And so just to keep in mind with both ourselves and with our patients that just because something's over the counter does not mean that it's safe. But the struggle is once something has been granted that over-the-counter like permission or whatever it is, you're never going to get it back. It's never like you can say, oh, now you can't buy your aspirin at the grocery store, because people would riot. Okay, so contraindications, always with medicines. If they're allergic to it, don't give it to them. Like, that seems pretty straightforward. If they have a history of those GI lesions, like we said, if they already have had peptic ulcers, maybe they shouldn't be on something that, gives them peptic ulcers again. Sickle cell anemia, they don't want to be on NSAIDs if they're taking any of their other types of blood thinners. That's another thing to think about. I found this was really interesting. Your book went through that you can't take NSAIDs with acetaminophen, and it spoke about how they target different pathways, and so they shouldn't be taken together. And I was really confused by that because that's kind of the entire idea. So from my perspective, absolutely, you can take NSAIDs with your acetaminophen. So apparently we have a disagreement there with your text. NSAIDs are typically metabolized, like ibuprofen, are typically metabolized by your kidneys. Acetaminophen is by your liver, so there's not a lot of risk there. So I'm not really sure where that came from. Acetaminophen, important to keep in mind, acetaminophen is just for pain control. It's not going to do anything for inflammation, okay? And then also, acetaminophen does have a pretty hard and fast 4-gram per day limit. And so if you're taking the recommended, 2 tabs every 6 hours or whatever, that's 4 grams in a day. If you go over that 4 grams, you are putting yourself at risk for liver damage. Okay, so talking more about those corticosteroids, the side effects really depend on the dose and the route. For injections, potential for, tendon rupture. Inhaled, we'll talk a little bit more about that later on. Inhaled corticosteroids are used most often in people with asthma, potentially COPD, but hopefully most of your guys' patients don't have COPD yet. In inhaled corticosteroids, their goal is to help decrease that inflammation in the bronchioles and help decrease that spasm. Important to know that inhaled corticosteroids have a really slow onset, like typically 1 to 4 weeks of therapy before you're really seeing any benefit. And so you can't use it as a rescue. Like, please don't, if somebody's, short of breath, you can't grab their inhaled corticosteroid. It's not going to do anything. Okay. Side effects with those could be dry mouth, sore throat, or even like fungal infections like thrush. So it's important that they wash their mouth out after using that medicine. And we talked already a little bit about the oral side effects of steroids. These are considered more like short courses, like a week, maybe 2 weeks. If people are on corticosteroids long term, then they're at risk for things like Cushing's disease and that big moon face and the humped back and all sorts of other issues. But hopefully most of your patients won't be on them long term. But the more of the short term things are increased appetite, restlessness, insomnia, fluid retention, again, GI disturbances, and it alters the glucose tolerance. There's also, roid rage is a real thing, and this falls into that category. Prednisone can make people pretty prickly for a few weeks, so it might be something fun just to give them an FYI. Anyways, yeah, obviously if you can talk a lot, you're really not that short of breath. Okay, speaking of which, bronchodilators. So we just talked a little bit about that with the inhaled corticosteroids. So the biggest instances that you guys will probably be dealing with this would be like exercise-induced bronchospasm or asthma. That exercise-induced bronchospasm is the most common cause of airway constriction that requires treatment with bronchodilators in the athlete. And these are those beta agonists. So they latch onto those beta receptors and cause them to relax the smooth muscles surrounding the bronchioles and let more air flow through. Okay. Albuterol is the most common. There can be a lot of different options, but albuterol is the most common. It's the cheapest, so it's most available. Go through box 5-1 to go through like proper technique. You'd think that it's pretty straightforward, but I had a patient who just kept coming to me over and over again saying, my albuterol isn't working. I'm still wheezing. I don't know what to do. And I asked her to show me how she used it. And she grabbed her little inhaler and she like spritzed herself with it like it was perfume. And so that's how we got to the bottom of the fact that her bronchodilator wasn't working. So not only do you have to have the right medicine, but you need to be using it the right way. Nebulizers are nice because they're machines that use air pressure to aerosol that drug, and then that delivers the quickest onset of action and actually maximizes the amount of drug that is absorbed into the person's lungs. When we think about side effects, albuterol can cause tremor, and really all the bronchodilators can cause tremor, nervousness, dizziness, headache, nausea, and some tachycardia. So oftentimes these happen more often with more use. So there's typically like that you can take 1 to 2 puffs, Q2 hours PRN. 2 hours is typically the shortest time frame that we use, because any more often than that, people's risks of these are a lot higher. And oftentimes I actually even have it closer to like every 4 hours. And then sometimes, unfortunately, you get a paradoxical bronchospasm. So people are taking this medicine to help relieve their weaving from their bronchospasms, and then it actually sends them into the bronchospasm. So that occurs in about 8% of people that use bronchodilators. So often enough, we need to be aware of it. Other medicines, your book goes into like excruciating details for you guys about anticholinergics, which are mainly used in COPD, leukotriene modifiers, which is also an asthma thing, so like singular or mast cell stabilizing medications, but I didn't feel it was super warranted for you guys to, dive deep into those, but really just know or be aware that these are medications that could be used. Antihistamines. So I want to give you guys a little tip when it comes to studying anything medicine related. If you can figure out or understand how something works, it's going to save you a lot of time, because there, as I'm sure you've already experienced, there can be like laundry list long lists of either symptoms to memorize or other things to happen. But if you can understand how it works and why it works, it can help cue you into what you should be looking for, okay? As opposed to just memorizing, because that's a pretty fast, easy brain dump, versus if you can conceptualize some of these things, then a couple years down the road when you've forgotten, you can help think through it and be like, oh yeah, I guess that does make sense. So let's think about that through with antihistamines. So where are the receptors? So hold on, let's back up. So antihistamines block histamine receptors and prevent histamine from binding to those cells' receptors. So let's think about, where do you think these receptors are? Okay, logically, where do you get asthma, or where do you get allergy symptoms? In your nose, in your eyes, in the respiratory tract. You can get hives on your skin. So that's logically, that would be where the receptors are, okay? But just fun fact, the majority of allergy receptors are actually in your nose, and so the best way to treat like seasonal allergies and such is actually with nasal steroids, okay? And then another fun fact, if you're using like a Flonase or like an over-the-counter nasal steroid, use your opposite hand to insert into this nostril, because it'll make it so that the spray gets more of those actual histamine receptors, okay? The first generation medicines are like your Benadryl, and those are considered the sedating antihistamines. Second generation are considered non-sedating, which really just means less sedating. And that would be like your cetirizine and such, and Claritin. Allergy treatment, like I said, is best with prevention better than reaction. So if you can get medicine on board before symptoms start, you're gonna go a lot further than if you just react after people have symptoms. Decongestants stimulate the alpha adrenergic receptor, which results in vasoconstriction, often used obviously with like cold, sinus infections, those kinds of things. Important to note that pseudoephedrine and phenylphrine are no longer listed in the NCAA bylaws as banned drugs. Okay. Also keep in mind pseudoephedrine, and with this vasoconstriction, it can really drive up people's blood pressure. Yeah, this was like the majority of my academic education. It can be really easy to, read through all of this, which is why I talked about, the importance of conceptualizing some of these principles to save yourself from just trying to blindly memorize. Oh goodness, the topic of the century, narcotics. Okay, so narcotics stimulate the opiate receptors, which cause analgesia, sedation, and euphoria. It's important to remember that narcotics do not decrease the level of pain. They just change how the pain is perceived, okay? And especially the opiate agonists cause this like dissociation from the pain. And we know that they have quite a bit of addiction potential. It doesn't have to be people who are on narcotics long term. I don't have the exact numbers in front of me, but so many people who actually end up with narcotic addictions, like the vast majority, started with a legitimate prescription for an acute injury. And that's why the DEA monitors, or that's part of why the DEA monitors these prescriptions so tightly, because there is such addiction potential with them. And it's complicated to say, are people addicted to the medicines themselves, or are they just addicted to getting a little bit of relief? A lot of these people are in chronic pain all the time, and if you're hurting all the time, it makes sense that, you know, if you finally get a little bit of a breather, why you would feel so great in that time. So we do have to tread so lightly when our people are on narcotics. Okay, side effects. Constipation, like we just said, physical dependence or addiction, sedation, drowsiness, dry mouth, blurred vision, urinary retention, nausea, vomiting, more histamine release, obviously respiratory depression. I'm not sure if you guys are trained or ever go into like Narcan usage, but that's when Narcan is used, is for suspected opiate overdose. Okay. It's important when people are on narcotics to avoid alcohol and anything else that could cause central nervous system sedation, because that's when people really get into trouble, is when things are combined and then it just really sedates that central nervous system. And then an important question to ask, and you guys are better at this than I am, but if somebody's in enough pain that they need that much narcotic, should they be participating in events? And this is a complicated issue and probably an entirely different discussion, but I'm sure a big part of it is like, you know, what event and what age and how important is it? Like, is it a third grade, you know, soccer game, or is it, you know, the Super Bowl? Like, obviously that makes a difference. Whether it should or not is a different conversation, but something to consider. These types of medicines always have the disclaimer to avoid operating machinery, which I think is funny because, you know, most of us aren't routinely out there on forklifts and stuff. But think about, obviously, your car and such. You shouldn't be driving when you're on narcotics. And like I said, the vast majority of individuals take opioids for a legitimate pain. And they never experience a physical dependence either. So on both sides, the people who become addicted often start with a legitimate reason for them to be on it, and then they just get hooked, and then they have to keep trying to get it. Versus there is the majority of people do take it, you know, for a short term, and they never have any physical dependence. And so it's that balancing act between truly validating people's pain and helping prevent or decrease as much as possible the potential for addiction. Okay, local anesthetics, they produce that temporary localized loss of sensory function. When I think of this, I think of like when you go to the dentist. The autonomic activity is affected first, followed by loss of sensory function, and then, or pain, and then finally loss of motor activity. And so then after you get numbed up and then they do whatever it is they're doing, it reverses in the opposite order. So you get your motor function back first, and then sensory, and then autonomic. And then the side effects really depend on, obviously, where they're putting it. And then also side effects could be like burning or stinging sensation when the injection is given. And I swear, I'm guilty of this. You guys might be better than I am, but you'll just feel a little pressure is probably like the biggest lie we tell in healthcare. Because typically it's more than that. Antibiotics, Table 5-11 goes into classes of antibiotics, indications, dosages. Your book goes into great detail about the different mechanisms of actions, and I chose not to, you know, really hammer that into you guys, as, you know, as a prescriber. I had, you know, a couple month-long courses on how to make those decisions, and I thought that was a little bit beyond what we should be asking you guys to do. What I want you to be aware of is antibiotic resistance is a huge issue right now, and if there's any role that you guys can play in this, it's encouraging your athletes to finish their course of antibiotics. It's not enough to just take it until you feel better. You fully need to finish it. And antibiotic resistance develops because of either incomplete therapy, too broad of a spectrum, so choosing the wrong type of antibiotic, and then also prescribing antibiotics for truly viral infections. And sinusitis is a great example of that. The number needed to treat for sinusitis with antibiotics to actually benefit one person, I think is like over 10 people, because like the ridiculously vast majority of sinusitis is viral in nature. And then, but what happens is people come to us on day, 4 or 5 of their viral sinusitis. We give them an antibiotic, and then go figure, after a couple of days they start to feel better. But that's really not because of the antibiotic, but we just gave the virus enough time to run its course. And when I talk about broad spectrum or the different types of antibiotics, you either think of like the grenade approach, the shotgun approach versus the sniper approach. Okay, and those aren't official at all. It was just an analogy that I think of. So when I think of like a grenade, it's like I know I'm gonna like take out kind of everything in that area, but I don't know for sure where I'm aiming, but I can't risk missing, okay? So I'm just gonna chuck it in there. Versus with a shotgun, I have a little bit more of a better idea what's going on, okay? I still have some uncertainty, but I have a better idea where to aim at. Versus a sniper, this is the bug I'm treating. I know exactly what it is, and I know exactly how to treat it. So those are kind of the 3 different approaches for how we go about antibiotic. And a lot of them is based off what is the risk of missing. Antivirals, your book mentioned herpes and influenza, but we use antivirals for all sorts of different things. But in general, they're just not very good medicines. Your book wanted to highlight that, sometimes wrestlers get herpes infections through skin-to-skin contact. People think of, herpes, either cold sores or genital herpes, but it's not always that simple or cut and dry. Antivirals generally pretty well tolerated, malaise and headaches in about 10% of people, and then again, GI side effects. Once again, the Credible Hulk. Make sure you cite your sources. You can tell I did a lot of research because that's what a lot of these are. Antifungals, it's tinea and then based off of where it is. And lots of different options. You can always start with over-the-counter agents and see if that does it, and then if not, progress on to, like oral medications. Once again, we already talked a little bit about this, but supplements are not FDA regulated. They don't have to prove anything. And a lot of them are just, water soluble. So a lot of times they're just secreted in people's urine. And important to remember that, once you get to 100% of something, 200% isn't better. Like your body can't absorb more than that 100%. And then also to keep in mind, because this is one of the fads that we're in, that, all natural does not equal safety. Lava is natural. Anthrax is a natural occurring thing. Just because something claims the product of, or claims that, it's an all natural substance does not indicate that, it's a great option. And then these were some things that I felt that would be important for you guys to know. So this is, you won't find this stuff in your text. So one of the big things to think about is drug-to-drug interactions. If somebody comes in with something and we just cannot figure out what it is, we really got to look what was the last medicine added, and did we miss something there? Okay. Important also to know fluoroquinolones, that's a type of antibiotic that we give. It's a pretty heavy hitter antibiotic that can cause tendon rupture. So something to keep in mind for you guys if you have somebody with a presumed tendon rupture, that could be one of the causes. Also something to keep in mind, where is it metabolized? Earlier we were talking about ibuprofen and Tylenol and versus the kidney and the liver. And so if people have problems already with their kidneys or with their liver, it's important to know where is this medicine being eliminated by. And then, like we said, actions beyond what it's hoped for. I think I talked about this last time in that, I might give a medicine for one reason, but because of the way that it works, it affects a lot of other things. A good example is propranolol, which is technically a beta blocker for your heart. But we also use it for, headaches and anxiety. And so if I'm giving that medicine as an anxiety treatment, then I can expect that person's heart rate to go down and their blood pressure to go down because technically it's a heart medicine. And then I wanted to give a heads up to you guys also about antidepressants and the paradox that exists with antidepressants. Our world is anxious and our world is depressed right now. And unfortunately, in teenagers and early 20-year-olds, if they get placed on antidepressants, they actually have an increased risk of suicidality for several weeks. Okay, so just something to kind of keep in mind. If things are going on that we all, as many people as can be aware of that risk, hopefully the better outcomes we can have for our patients.